I'm so excited to see that we have, I see like 81 participants in our session, so this is really great. So let me kind of begin by sharing my slides. So today I'd like to kind of direct the focus of our discussion on what it means to give birth during a global health crisis and understand kind of the impact of giving birth during these challenging times on mothers' wellness and the impact on the infant. And I'd like to begin with a case report. This is a case report of an individual who gave birth in New York City at the end of March, kind of roughly, we could say this would be the peak of the first wave of the pandemic in the US. And she talks about not having a support person when she's giving birth, being all alone, being treated like an assumed COVID patient, and importantly, as a result, being isolated from her newborn. So possibly this brief report of this pre-empowerment woman might be a reflection of experiences that many women experienced during the peak of the pandemic. And if we think about 4 million American women giving birth annually, that would mean that there is 100,000 of women who give birth in a given month, possibly some giving birth at the peak of the pandemic. And it's important that we begin to kind of, as I know that we have begun already, but to kind of reveal the unique stressors that were imposed on postpartum women and women who gave birth during the pandemic, to really understand how these unique stressors, which might not be relevant for other populations, such as, the concern of transmitting the virus to the newborn via breast milk, the giving birth in a hospital that is kind of under the pandemic regulation, etc. Understanding how these unique stressors impact not only the immediate response of women following childbirth, their kind of mental health adaptation, but really their trajectory, how they cope over time, and how, as we all know, their coping potentially might be an important predictor of the well-being of their children. So I believe this was in April 2nd, we launched an international study, which mostly included women who reside in the US. We really wanted to understand the impact of giving birth during the pandemic on maternal postpartum adaptation. Our final sample of women who took part in this study included more than 3,200 women. The majority gave birth in April or March in the US. And we had a small group of women that we call them the controls. We would be, as you can see here on the left side, 666 women who actually gave birth before the pandemic. And we really wanted to understand the unique added stressors of the pandemic and how these stressors impact coping. As you can see, traumatic experience of childbirth have drastically increased during the pandemic. We see that roughly nearly 1 out of 4 women who gave birth during the pandemic had an acute stress response to childbirth. And I want to kind of emphasize that in this analysis, we excluded women who were positive for COVID. So this, we can argue that acute stress response has been heightened among healthy women who gave birth with no, at least, added physical complications because of the pandemic. And more so, you can see that if we examine the acute stress of women who gave birth to the pandemic versus the acute stress response for women who gave birth before the pandemic, and we basically created these matched control groups. We matched women who gave birth before the pandemic versus those who gave birth after the pandemic on various demographic factors and prior mental health, prior obstetrical complications, to really understand the unique impact of the pandemic. And we see that the increase is roughly 40% increase in rates of acute stress to childbirth. I wanted to emphasize that we measured acute stress response to childbirth by a questionnaire, which is called the Perinatal Distress Inventory. As you can see here, PDI cutoff of 60 and above. And the PDI is a questionnaire that is commonly used to assess traumatic reactions following known traumas. And for me, known traumas, that would fall under the category of sexual abuse, combat, and terrorism. So 1 out of 4 women who have acute stress following childbirth during COVID-19 in a healthy sample, I believe is really a lot of women who potentially are at risk for developing mental illness. And we found in the same sample that this acute stress response to childbirth is predicting having a maternal postpartum stress disorder following childbirth. So women who have acute stress response to childbirth, which basically means that they kind of they perceive their experience as very traumatic and they respond accordingly, this acute stress response could for some lead to developing maternal PTSD. And importantly, the acute stress response is also potentially, not surprisingly, associated with reduced mother-infant bonding during a critical time to make sure that women are able to actually successfully bond with their infants. I want to just kind of, divert our attention to maternal PTSD, because again, the acute stress response potentially is mostly correlated with maternal PTSD. And maternal PTSD is a slide that I like to show often in students in my lab. As you can see here on the right side, we found in a different sample that 81% of those who have maternal PTSD, childbirth related, did not have PTSD beforehand. Only 90% actually had PTSD before they gave birth, because I often hear this argument that maybe we're just kind of studying women in the postpartum, so we are able to identify a lot of pathology. But based on our prior work, we see that the maternal PTSD is basically triggered by having a traumatic delivery. Without being exposed to a traumatic delivery, you would not have maternal PTSD, suggesting that the pandemic, by increasing the acute stress response of mothers following childbirth, this has also increased the rates or the prevalence of maternal PTSD, which we know based on studies before the pandemic, roughly 240,000 American women are likely to be affected by maternal PTSD and their infants based on studies before the pandemic. I regard this condition as extremely debilitating because the core pathology of PTSD in general is that the symptoms are triggered by a reminder of the trauma. In the case of maternal PTSD, the trauma is childbirth. This would mean that potentially the child themselves could become a trigger of the maternal PTSD. Here in this slide, you can see that we asked women to mentally image their childbirth experience, and then we measured heart rate, skin conductance, and EMG corrugator, and we found that these women's physiological responses during this imagery of childbirth, or recent childbirth, were actually higher than reported cutoffs, which is really the dashed line that we see among survivors of other trauma. In this case, I refer to combat veterans. So I'm thinking about a woman who has maternal PTSD. She, as part of the maternal PTSD, she would be haunted by these intrusive memories of childbirth. The memory of childbirth would entail the child. And possibly we're talking about COVID-19 leading to a acute stress response in childbirth, amplifying the occurrence of maternal PTSD, which could have cross-generational effects because the pathology is triggered by traumatic reminders, which is a child themselves, suggesting that the child could be a constant reminder of the trauma, and the child themselves would trigger their maternal PTSD. As we all would know, this is a very vicious cycle. When the child is triggering the pathology of the mother, this could lead to impairments in mother-infant bonding, as we found in our COVID sample. So it's important that we really identify the women who are at the heightened risk for developing acute stress response to childbirth during the pandemic. As you can see on the right side of the slide, nearly 50% of women who were COVID positive, reported COVID positive in our study. Nearly 49% had acute stress response to childbirth at a clinical level. So really they were at a heightened risk for developing PTSD. Again, I consider 49% as a very high rate of women at risk who perceived an event that is supposed to be a joyful moment as very traumatic. And this is definitely 3 times more than women who were negative for the virus. And clearly there could be many reasons why women who are COVID-19 positive had an acute response to childbirth and potentially at risk for developing a mental pathology. It's likely that the birth experience became more traumatic because women gave birth when there are potentially some of them suffering from severe physical symptoms. But it could also be that there are what I would consider these contextual factors, environmental factors, which also amplify the traumatic nature of childbirth. And this would be, as you can see on the left side, women who were COVID-19 positive, a larger portion of them did not have visitors when they were admitted to labor and delivery and in the postpartum during maternity hospitalization stay. And some of them in our study were not rooming in, this is rooming in rates, not rooming in with their infants, not because the baby was in the NICU, but because they were they needed to isolate from their children because of carrying the virus. So just kind of, to make the argument that possibly these added contextual stressors, which would be not having visitors, not permitting a support person during labor and delivery, has amplified the traumatic nature of childbirth. As you can see here on the right side, women who did not have visitors, versus those who had at least one visitor, they were 3 times more likely to develop or to report acute stress response at a clinical level following childbirth. So even kind of having one visitor, at least in our sample, made a big difference. I also would like to kind of direct a lot of attention to the experience of certain populations, in this case, underrepresented minority individuals, during the pandemic, and how the childbirth might have been more traumatic for these individuals. As you can see here, we found that women who identified as Black or Latina, these individuals were nearly three times more likely to report acute stress response in childbirth, 2 times more likely to report postpartum depression at a clinical level based on EPDS cutoff of 12 and above, less likely to breastfeed with their infants, less likely to room in, less likely to do skin to skin, and 2 times more likely to report undergoing an unplanned cesarean. Now, clearly, there could be a lot of inherent differences between women who are identified as Black or Latin women versus individuals who are non-Hispanic white. So the result that you see here is basically, again, we applied these propensity score matching, and we wanted to see whether there are differences in childbirth outcomes comparing between underrepresented minority and white women when we control for demographic factors. And we see that even when we control for demographic factors, and even when we control for mode of delivery, and we control for obstetrical complications, and we control for report of prior trauma before giving birth, and we control for prior mental health, nevertheless, we still see in our sample that unfortunately underrepresented women had poorer outcomes than non-Hispanic white women. This really warrants making sure that all women are receiving the care they need, especially during the pandemic, and warranting making efforts that we find ways to eliminate any racial and ethnical disparities that would eventually lead to negative mental health outcomes in a certain group of women who live in the US. I also thought it would be interesting to show that this is as might be expected, that the acute stress response, potentially perceiving the birth as traumatic and increased fetal maternal PTSD, did vary during the pandemic per state. And as might be expected, states that possibly were more impacted by the virus, that there was more individuals who were COVID positive. As you can see here on the slide, we compared rates in Massachusetts versus New York and California. And we see that if you look on the all the way on the left side, Massachusetts versus New York, in New York, there are more incidents of not having visited in childbirth. And in California, there are more incidents of not having unplanned cesarean, of having unplanned cesarean during the pandemic. And possibly this increase in rates of unplanned cesarean and increase in, or having these conditions of not having a support person during childbirth might in part explain the differences between the states. And again, this was done by excluding women who are COVID positive for the virus. And again, pretty much a similar pattern we find for postpartum depression using EPDS cutoff of 12. We see that there are higher rates of maternal postpartum depression among women who reside in California. And if you look at during the pandemic and we compare women who reside in New York versus women who reside in Massachusetts, then we see that in this kind of big inner cities, very big states, potentially highly impacted by the virus, there is unfortunately much more higher prevalence of mental health disparities. So it's really important that we begin to understand how can we reduce the impact of the pandemic on kind of these enduring negative mental health outcomes, such as maternal PTSD, such as bonding impairment, for women who have acute response to childbirth. To remind everybody, currently in the US, at least to my knowledge, in hospitals, we screen for maternal depression. There is no kind of routine way of screening, at least in my hospital, Massachusetts General Hospital, for screening women who potentially had a traumatic delivery, psychologically traumatic delivery, and then might be at risk for developing maternal PTSD. We also know that a significant portion of women tend to underreport endorsing psychiatric symptoms. So often questionnaires are not really the best way for us to understand the prevalence of the condition and potentially direct clinical care to women who might feel uncomfortable to report their symptoms. And we also know that potentially, to some extent, questionnaires might not be that cultural sensitive. So what could potentially be another way in the case of maternal PTSD or traumatic childbirth experiences to really accurately identify women at risk before the pathology develops? And in the case of maternal PTSD, it's especially important because we know, based on studies in general PTSD, that following traumatic exposure, there is what we call this kind of golden hours, a window of opportunity. During these hours, it is hypothesized that there is these very crucial causal biological processes that occur, that if we are able to intervene during these kind of golden hours or days in the really early time following traumatic exposure, then we might be able altogether to even avert the PTSD trajectory, meaning we might be able to prevent PTSD. In the context of other traumas, excluding childbirth, it's also often almost not feasible and impossible to be able to find survivors following traumatic exposure. In the context of childbirth, given that for some women the birth would be traumatic, and we know, as I said, during COVID, for a significant portion of women, the birth could be traumatic, because women are in the stay in the postpartum maternity unit following after they give birth, we might be able to early on screen women and potentially avert the maternal PTSD pathology. So one way that we began thinking about finding new ways for screening women and identifying those who are at heightened risk is by collecting narrative accounts of childbirth. So kind of collecting narrative accounts of childbirth really within the first hours, if not days, following childbirth when women are in the hospital, and examining whether the use of the language could then help us identify the group of women that we know eventually would develop PTSD. The use of narratives potentially would be a reflection of the subjective experience of childbirth. In the context of acute stress response and maternal PTSD, we know that in many ways the subjective experience of the birth or subjective experience of the trauma is a salient factor, possibly potentially more important than the objective magnitude of the trauma. So if you think about women who have obstetrical complications, based on our research, we know that only if they perceive the event as highly stressful, if they perceive their experience and their complications as stressful, they're likely to develop PTSD. If the event was not perceived as stressful, you're less likely to develop PTSD, even if you had severe complications. Although clearly, if you have severe complications, you're likely to perceive your birth as more traumatic. So we applied kind of machine learning and asked women to, in our COVID-19 sample, to generate very short childbirth narratives. We didn't actually limit the word count, but on average, most women reported, freely reported around 200 words. And we just looked at these very short narratives, which we asked women to freely describe their birth experience and focus on the potentially most stressful components of the birth, if they exist. And we used word bending, and we additionally kind of used natural language processing, which I don't want to get too much into this, but basically this is the idea that you not only examine differences by examining the frequency of certain words in the text, but you really have a unique way to understand the prevalence of a certain word within the context of the sentence. And we saw, as you can see on the upper left side, that women who were distressed actually reported in general more words than those who were not. And I think that's kind of offers some level of feasibility that we will be able to collect these early on accounts from women who had traumatic deliveries, because women want to talk about their childbirth. And more so using kind of machine learning models and the natural language processing, the BERT model, we found that if you look at on the lower part of the slide, 80, and we look at the recall, for example, 0.81, this would mean that of those who identified as having maternal PTSD, this was based on the PCL cutoff of 33 and above, which is, again, is a very high cutoff, and we use the maternal, the PCL as the PTSD check is for DSM-5. It's a questionnaire that is potentially the standard questionnaire to assess PTSD in combat veterans. We see that roughly we're able to identify accurately 80% of women who actually go on and develop the pathology. This is really only in the pilot phase, and we're really kind of excited to continue and analyze larger samples of women and to see whether generating not more than 200 words might be a way for us to begin thinking about creative ways that we could easily, with very low cost methods, screen accurately women during their maternity hospitalization state to eventually prevent a very debilitating disorder. I'd like to end my presentation by, again, going back to these case reports of women that so nicely volunteered to take part in our study with really actually no monetary compensation. Just to give you the time to read the different short segments which were kind of taken out of their 200 length narratives. And as you can see here on in red on the right side, this individual says, please make sure women have the support they need after 6 weeks. So I'm gonna thank again all the members of my lab, the students, my collaborators from the OB at Mass General, Angelique Kemal, Lauren Henley, my collaborators at Yale, Linda Mays, and NA.